Okay. Why don't we go ahead and get started? I do want to make sure, did everybody pick up the handouts in the back? Because you're going to need them for in a little bit later. So make sure you have both handouts. I'm Alan Court. I'm the CEO at Children's and the chair of the Department of Pediatrics. And this morning or afternoon, we're going to be talking about RCAs, root cause analysis. And these are just the objectives which hopefully you will be able to accomplish by the end of this session. But RCA is, we're going to be talking about a tool or a process to look at bad events. I want to give thanks to the people who actually put a lot of this talk together, from the VA National Center for Patient Safety, especially Edward Dunn. And whenever I think about giving thanks, I always think about church. And I did want to tell you one story that I heard the other day, which was there was a little girl who was in church, and she turned to her mother and said, "Mommy, I'm sick. I think I'm going to throw up." And the mother said, "Well, go outside, run outside, and go throw up in the bushes behind the church." And the little girl disappeared. And a few minutes later, she came right back, and the mother looked at her and said, "Well, that was awfully fast." And the little girl said, "Well, I didn't have to go way around in the bushes. There's a little box right on the side of the church that says, 'For the sick.' And I threw up there." So, anyway. So we're going to talk a little bit about what an RCA is, why do you do an RCA, and then why should residents be involved in RCAs. And then we're going to talk a little bit about how you actually do one.
LAX, this is AM 117 Heavy requesting emergency approach. AM 117, come about to 175 and proceed to 3,000 feet. Roger that, LAX. We're not going to be able to make that approach. We're having trouble maintaining altitude.
Shaping up to be a rough commute out there today. Watch for an accident on the 101 near Sherman Way. And we're just getting word that the 405 southbound has been shut down completely. Looks like some sort of police activity's got it cleared for a 2-mile stretch from the 118 all the way up to Victory. As soon as we get more information, we'll let you know. But in the meantime, we'll get you through with another 40 minutes of your favorite hits on KPTV.
Okay. So why do we show that in the beginning of a talk about RCA, root cause analysis? Well, first, because it's I think it's fun. I think it's pretty hilarious just to watch it. And secondly, because do you think they did an RCA about what happened there? Do you think the airlines does an RCA every time there is a near miss or an accident? Absolutely. And what they look back and they try to get to the root cause of what happened. And that's what we try to do in medicine now, and have adopted this for the last probably 10 to 15, almost 20 years. One of the other things that that film always brings up, though, is what my grandmother always used to say, and that is, no good deed goes unpunished, as you saw from the little old lady. So why do we do an RCA, and what exactly does it look like? Well, it's really a process. It is a tool, it is a process that we use to look at medical events that occur where there is either a near miss or there's actually a bad outcome. And it also is very interdisciplinary. It involves everybody, but especially the front line. We're going to talk about that a little bit more in a minute. One of the things to remember is that there are a lot of adverse events that happen in medicine. So you can think about all the adverse events that happen with medications and the reaction to medications. And then there are a lot of medical errors that we make, but a large percentage of those never reach the patient. The ones we hear about most of the time are those that actually harm the patient. And those are the ones we're the most concerned about. But actually, by looking at medical errors that don't reach the patient, we're going to be able to do a better job of preventing them in the future. So what I'd like you to do now is go into groups of about 4 or 5, and I want you to discuss among yourselves for about 4 or 5 minutes a case that you know of where there was a medical error. So if you can just get together in groups of 4 or 5, and then write down just a little bit about that case on the back of your handout, that would be great. So about 4 or 5 minutes, and just write down a case that you know of where there was a medical error. Okay, about another minute. Okay, what I'd like to do now is, who would like to volunteer, or do you want me just to pick somebody out? And tell me about your case and where the medical error was. And maybe we can start with the group right over here. Do we have a microphone for them?
Just talking.
All right. My case was one that happened with neurology. It was a patient who previously he had a stroke and he got TPA. He was inside the TPA window. Everything was doing fine, but he was transferred to a larger hospital where I was. And then what happened was no one realized that his neuro exam was kind of degenerating, even though he was on Q2-hour neuro checks. And then by the time that they realized or someone actually spoke up about it, he had a really large hematoma, not very good quality of life. They decided not to operate or anything, and so he died from it. But
Okay. All right. How about the group right next to him? Right here, yeah.
Well, sir, what we noticed that a patient came in for a standard hysterectomy, and it was transabdominal, and basically there were so many adhesions within their belly when the incision was made across the abdomen, it actually opened up her small intestines and required a bowel resection.
Let's pass the microphone over to this group right over here in the back. That'd be great.
So our case was actually on a patient that came in with candidemia, and they're going to change out the lines. So she had IR replace the central line. And on the PA film, it actually looks like it's in good position. IR stated it had good flow. Patient started complaining of nausea, vomiting, chest pain. On exam, she had crepitus. Lateral chest x-ray was performed, showed the line was actually in the anterior chest wall. And she'd had 2 to 3 days of TPN. She was on chronic TPN.
And one more, let's go in the back behind you, all the way in the back row that likes to hide back there. Somebody back there. Well, anybody right in that group right there.
Okay, well, we were medical management consults for a surgical patient. We wrote to start heparin injections post-op day 1 if okay with primary. Primary was never asked if that was okay. It never got started. Developed a DVT on post-op day 2.
Okay, great. So what you've really heard are a number of different errors that were made that had different levels of effects on the patient. So let's come back for a minute and just talk a little bit about RCAs. So it really came from what's called the failure mode effect analysis, which is part of a quality improvement program. And it was really used, obviously, started out in the military and really looked at equipment failures. And also it's been used for the Apollo program and in manufacturing and the auto industry. The best place that I can think of to do an FMEA in a hospital is when you build a new unit. And before you even have a patient in that unit, you should go ahead and check to see how everything works. So you really should do a simulated case. And I can give you a bad example, and that is that at Children's we built 2 new ORs. They are state-of-the-art. They have incredible equipment. But nobody ever actually looked at the surgeon flow inside what is called the 4th OR. And so when they want to do a case, they keep bumping into the table and then the desk that's next to that, there's not enough space. And so they've looked at all the different things they need to do, but that should have happened and that should have been looked at long before they started doing surgery there, and it was not. Most of you have heard, I think, in your quality improvement talks, hopefully now, basically there are many different methods of quality improvement. And the ones that most people are familiar with are obviously PDSA, and that's the one that we use here for the majority of our quality improvement work. There's also a process called Lean, which actually looks at how do you decrease and get rid of duplicate activities, how do you get rid of everything from duplicate steps to duplicate processes. And then there's another thing called DMAIC. And DMAIC is a Six Sigma program which is usually run by black belts and green belts in quality improvement. And DMAIC stands for Define, Measure, Analyze, Improve, and Control. But in the analysis part of it is where the RCA comes in, where you really look at it and say, okay, what happened? And where did, how do we, what was the outcome of what we did before? And so the most important part of this slide is to look down here, because this is a fishbone diagram. How many of you have seen fishbone diagrams before? Good, that's great. And it's really a way of looking at and finding different categories and how they affect the patient. And in this case, around diabetic patients not getting eye exams, looking at education, the computer orders, the cost for it, and appointment delays. But it's really how do you diagram and look at all of the causes for a particular event. And then from the model for improvement, as you know, one of the most important things about RCAs is to make sure you're actually improving the system and you're not just creating another workaround. And again, this is from the PDSA cycles. So how many of you know about the Quaid twins? Anybody in here know about the Quaid twins? Okay. The actor Dennis Quaid and his wife had a set of twins. And they were in the hospital in Los Angeles. And they were in their ICU. But they were getting better, they were growing, doing fairly well. And they were, had a line in, and the line had heparin in it. And somebody made the mistake of using a concentration of 1 to 10,000 units rather than 1 to 10 units. And the interesting part of the story is that the mother called up to see how the kids were doing, and she said, I just don't feel right about my babies. She actually went into the hospital, and by the time she got in, the babies were bleeding from their umbilical stump. They were bleeding from their rectum. They had bleeding everywhere. Fortunately, they did not have an intraventricular bleed, and they've done okay. But it really brought to light the fact that these medical errors happen, and they happen all the time because our system is so complex. The other interesting part of it is within the next 6 months, there were 3 babies who died at an Indianapolis Children's Hospital because they were given the wrong dose of heparin. So it's not something that is unique or doesn't happen on a frequent basis. And in fact, the data from To Err is Human, which was published almost 20 years ago now, 3.7% of all patients are hospitalized because, who are hospitalized have an adverse event. And a lot of those are related to drug events. And it's estimated that 120,000 people die each year from medical errors. So there are actually more people that die from medical errors than those that die from motor vehicle deaths. Pretty sobering number when you think about it. And there are almost as many die from medical errors as from stroke. So again, that's why we do RCAs, to prevent those medical errors. So the National Center for Patient Safety has an RCA model, and it's rigorous, it's legally protected, it's all confidential. And what it looks at is when there is an event, what do we do and how do we go back and look at it? And it specifically looks at what happened on the day of that event. And it goes back and just like a trial or something else, basically gets everybody who was there around that event, all the different disciplines, and talks with them about what happened. And then it compares that to what should happen on a normal basis, and it also compares that to what does our policy actually say should happen. And then tries to get to why did it happen and how are we going to prevent it from happening again. And then what metrics are we going to use to measure and make sure that it doesn't happen again.
In a hospital setting, when there is you want to conduct an RCA, who convenes that group? Who directs that process?
We're going to talk about that in a minute, but basically it can be, technically it's the CEO, but the CEO designates that to a number of people. So the chief quality officer can call that. Certainly anybody a medical director on the floor, medical director in surgery. I mean, anybody can ask for an RCA. But here it's all, RCAs are almost always a follow-up to a report that you've put into the occurrence reporting system. But it's when somebody raises the issue and then a group is convened and brought together. So the goals really are to have that tool to look at and prevent what happens. And it says, as you notice, prevention, not punishment for adverse events. Now, I don't know how often it happens today, but when I was in training, when we did an M&M, what was the main purpose of doing the M&M? Looking to see what? Who screwed up? And pointing the finger. And we no longer do that because we realize there are a lot of human errors, but there are reasons for a lot of human errors. And so what we look at now instead is what is the system and how do you fix the system to make it better? And how do you make the system so that that human can't screw up? There's also a whole area of culture of safety, which we at Children's will be going into a phase starting actually in the next couple months of looking at how do we improve our culture of safety? How do we actually get people so every minute of the day they're thinking about safety? One of the interesting studies about nursing is that a lot of nurses feel that they spend so much time recording data and putting data into the chart that they don't have the time that they need with their patients. They don't have time to sit by the bedside. And they also don't have time for what we call critical thinking and situational awareness, so that they're actually paying attention to the patient. And I think that's something that we all have to think about as we go through our routines every day. Okay, and then the measuring and tracking the outcomes is very important. So why should residents be involved in RCAs? Maybe you shouldn't. You already got a lot to do. So why should residents be involved? Right. Helps you with what is called systems thinking. So absolutely. Why else? Who is the person, along with nursing, who is the closest to that patient? Who touches that patient more than the attending, than anybody else? It's really the residents. And you're the frontline staff, and that's why we involve you. So there are a number of reasons. You really know what happens at what we call the microprocess level. That's down on the front line. You are the front line. And somebody always asks me, why do I think it's safer to be in an academic hospital where we have all these young doctors who, are being trained, than to be in a private hospital where you only have attendings? So what's the data? Is it safer to be in an academic institution or in a private hospital with private attendings? Anybody know the data? It's safer to be in an academic hospital. And that's been proven time and again. And there are several papers on that. But basically, the reason is because you all are another set of eyes and ears and hands for that patient. And you really do make a big difference in the safety of how things are done. Now, the other thing is that when they looked at nationally, how often are residents involved as RCA team members? Less than 1% of the time. All physicians, only about 15% of the time. So obviously, we need to be involved a lot more in what happens. So what's in it for you? So why should you do this? There is a residency requirement around patient safety and systems thinking. But why should you care about what happens, and why should you be involved? And I've already told you, you're at the microsystem, you're at the front line, you're the one who can give the information. But it's also a component overall of quality improvement. And everyone, as we recently had the CLEAR inspection, everybody has to be involved in quality improvement. You also need to understand the language, and even the language of an RCA, and know what an RCA is. Obviously, you'll also be doing QI efforts, and once you go out into practice, you have maintenance of certification, which now also have quality improvement requirements. So the other thing is that you can actually put an RCA on your procedure log. And so when you keep track of all of your procedures, you can actually put that down and put the RCA in there and your involvement in that RCA. And it's a core competency with the ACGME. Okay, so again, as I've said before, the RCA model focuses on prevention, not on blame or punishment. Focuses on the system. It looks at communication, the environment, what happened that day, the training. It also looks at rules and policies, and also looks at things like fatigue, scheduling, and other barriers. And then just restates what I already said. And the other time that an RCA is done is whenever the Joint Commission designates something as a sentinel event. If you leave something in a body after surgery, that's a sentinel event, that gets reported to the Joint Commission and has to have an RCA. Now here at Erlanger, we also do RCAs for small events, and we do small, what we call brief RCAs for CLABSIs and CAUTIs and other hospital-acquired conditions. So every CLABSI has a small RCA done on it with the infection control folks and the quality folks in the hospital. Now we also do them on near misses. And as George Carlin says, it probably should be called a near hit rather than a near miss. But we use that to look at it, and again, it moves us beyond the blame and saying that safety is the thing we are the most concerned about, not pointing fingers, not the blame. Why do we use a particular method? Because medicine is so complex that there are actually checkoff boxes in the RCA process. And we also bring a lot of biases, and the whole reason for an RCA is to have enough people together and people who are used to doing it, so those biases are removed. How often, well, I don't know, but how often have you all been in an M&M or been a discussion of a case where an error happened and you heard, well, it was the inexperience of the resident? David's heard that. I certainly have heard that. But that's a bias, because one of the things we do as human beings is we jump to a conclusion long before we really have all of the evidence. So it's really to try to avoid those biases that we all have. So when don't you do an RCA? You're not going to do an RCA when it's a criminal act or intentionally unsafe acts. Where there's any question about alcohol or drug use or patient abuse. So how does an RCA work? The medical director, as we talked about, Robert, the medical director, quality, patient safety, whoever, can actually put a charter memo together. There's an RCA team that's brought together, and then that work has a time frame, and it's almost always now not 45 days. It is a matter of a couple weeks at the most. And then the CEO and everybody that's involved around what happened come together and say, what are the proposed actions? What do we need to do? How do we prevent this from happening again? And we pull that team together, and they're usually 4 to 6 people, and there's a flow diagram, which we just talked about, that's there, that people will walk through, and then root causes are determined, and then we go in and say, okay, what happened? So this is the cause and effect diagram, and you all have a copy of this. And most of the time we look at it and we say, okay, what was caused by the people who were there? What was caused by the environment? What was caused by the equipment? And what were caused by the methods of how people did things and the materials? Now, another way to look at that is looking at actually the structure. What was a problem because of the culture of that unit? And many times the culture of a unit is where people will take shortcuts to get something done. And those shortcuts can sometimes end up actually causing the medical error. What were the processes, the policies, the protocols, technology, environment? And then the other thing that we look at also is just the human error. And what's the competency of the person involved? How conscious was that person? You know, how much was there inattention or distraction? And how much fatigue? And then just what we call lapses. How often were there lapses and somebody just didn't pay attention to what was going on? Number one cause of medical error, communication. Where we don't communicate and we don't help somebody else anticipate. When you guys do your sign-outs, how often are you talking about anticipating that patient who's going to go sour on that next shift and talking about that before it happens? That's how you prevent it. Critical thinking, we talked about this before, situational awareness, failure to validate, verify, and also just what your mindset is at the time, and then compliance. And there's actually a whole categorization around if you're reckless. And did somebody make a decision that was actually reckless? So what I'd like you to do now, and I'm not going to use this case because you all have them, but I'd like you to take the cases that you have and the fishbone diagram and talk amongst yourselves again about what were the causes for the event that you just talked about, and how would you go through assigning and getting to a root cause for that event. So everybody has your own little group. If you came in late, you can attach to somebody and just talk about what you see as the root cause for that event. Okay, why don't we start up again? And what we can do is, the first group that talked about the TPA and the patient who had this stroke, do you want to walk through what you came up with as you looked at the fishbone diagram?
Yeah, we'll go over a few things. So one part of it was the people. Apparently, it happened over a shift change, so there wasn't a great checkout, and so one person's neurocheck was different than the previous person's neurocheck, but there was no way to understand that difference because they didn't check it together. Moved into a busy, hectic ICU that didn't have close enough communication there. Didn't go over the neurocheck at bedside. All of those issues were stuff that we talked about.
Okay, so mostly you're focusing on communication. So
Correct.
what would you recommend to improve that situation?
One thing that we thought about was at checkout going over a neurocheck at bedside, and that way one person would see exactly what the other person was seeing at that time.
Okay, so is that practical? Is that doable?
There's already checkouts that are performed on every shift change, so I would think that it's practical. It may take a little bit longer, which does limit other patient care, so that there is some challenges to it.
Yeah, but especially on, you want them to use the microphone. Okay. We'll get you a microphone. But so as you do that checkout, you don't have to do it on every patient, but certainly on somebody who's unstable or new to the unit, you may want to do it, or where you're concerned about it.
Correct.
Absolutely. Okay, how about the patient with the hysterectomy?
Well, sir, a couple of things we came up with was, one, the people involved, so possibly the physician performing the surgery as well as the radiologist. Maybe there was something missed as far as how tightly adhered the small bowel was to the abdominal wall. Maybe there was better imaging that could have been done to foresee this. Also looked at the prior medical history of her to determine how many surgeries. She had well over 5 abdominal surgeries, if I remember correctly. So maybe there's some research that needs to be done indicating how many abdominal surgeries occur before complications and anatomical differences can occur like this, and then correlate that with the patient you're currently working on. And then perhaps a safer way to approach any type of potential anatomical differences like that during the abdominal opening to ensure that what you're seeing is actually what is.
So what you're suggesting is, are there any red flags or policies that should be developed so that somebody who's had X number of abdominal surgeries, you're going to look a little more closely
Yes, sir.
at what you're doing? So that would be actually putting a policy in place. Is there any literature on the number of surgeries and the number of chance of having significant adhesions to the bowel?
I'd assume there is, sir, but I have no idea.
Does anybody know? I don't know. But anyway, it certainly would be one of the things you can look at. Great. Okay. How about the patient with candidemia?
So the line was placed in IR, so there may be some issues with technique there that I'm not sure of, so that'd be something you'd have to investigate with them. And then a PA film was done, is that right? But not a lateral film, so maybe PA and lateral should be done after every central line placement, if possible. I guess that's very, very difficult. And really better physical exam. This patient's been getting TPA in their chest wall for a couple of days and nobody noticed. So there's a lot of places that the checks and balances didn't pick it up.
Right. So one of the things is there a policy about every patient who gets a new line, are they only getting a AP or are they going to get a lateral? Do we know?
I imagine they're mostly just getting AP, because a lot of them are in ICUs or not mobile, and it would be difficult and probably very expensive.
How expensive do you think it was? What happened to that patient was?
Very expensive.
Yeah. So I think you can do the cost justification without much difficulty. Okay. And then the patient who had the DVT?
Well, we lost our original spokesperson, but so we talked about just better communication between teams. The order said, start this patient on heparin if okay with primary team, and then that physician wasn't proactive about following up. The primary team either didn't see the order or didn't follow up, and then the nurse might have overlooked it or not thought to ask. And so it was just an example of just better communication and follow-up with everyone involved. I think sometimes if there's so many people involved, it's easy to assume that someone else is going to do it, and that can lead to a breakdown in patient care.
Okay. So if you go through an RCA and then the recommendation that comes out of it is, well, we need to educate people about X, Y, or Z. How successful is that in changing behavior? Say you put the education program together, you go out and you do it. How successful? Now, with this talk today, how much are you going to remember a week from now? How much are you going to remember 6 weeks from now? So the point is, how much does education actually change what we do? So does anybody know the number on 6 weeks from now? Absolutely. But from just a standard lecture or talk as opposed to simulation. Simulation is much better. You know, the old saying of, tell me and I won't remember, show me and I may remember some, and have me do it myself and I'll remember. But it really does make a difference, and that's why simulation is much better, a much better learning tool. But the studies that were done in the past on CME, about 10% of the material is actually able to be recalled 6 weeks afterwards. It also depends on your learning and where you are personally. If you're tired and have been on call all night, obviously you're not going to remember as much. But the reason I'm bringing that up is that it's much more effective if we put policies in place, but also put hard stops in place. And that's one of the real advantages of moving to an electronic medical record, is where you can put hard stops so things don't happen. And with all the problems around electronic medical records, it is one of the real advantages of electronic medical records to be able to do that. So after we do the RCA, we go back and try to let people know, especially those who reported an incident. We now have moved to a process, if you reported an incident in the occurrence reporting program, that actually we get back to you. We don't tell you exactly what happened, but we tell you that we're looking at it. And also what were the lessons that were learned, and then what are the actions that have to come out of it. And that's what I was just talking about. The stronger ones are permanent, that are focused on human factors, that are actually a physical hard stop. The weaker ones, just to say, well, you guys need to be more vigilant. And then we have to measure what the outcome is. And we have to go back and look. If we had that happen, what are we doing now? And what have we changed in what we do every day to make a difference? So the goals really are to find out what happened, why did it happen, what do we need to prevent it, and how do we know that we make a difference? And with that, I'll take any questions that any of you have. But basically, RCAs are there to take an in-depth look with the frontline staff and be able to say, this is what happened. The other thing is that it's there to do it in a non-biased way, because we all have biases in how we look at what happens. We all have those groups that we want to point the finger at and say they're to blame. And we also, as physicians, jump to conclusions very quickly about what the cause was. And we all need to take the time to really do a very thorough examination of what happened when we have a case where there was a medical error. So thanks, and have a great day.